lung function testing? Yeah, that's fine. Thank you very much for that. I was asked to do a lecture in lung function testing, and so that's what I want to do for the next hour. I've divided this lecture in two parts. The first part will be the background of lung function testing, and the second part will consist of examples of lung function testing. So the second part, at least, I think you can take part if you like. You can shout into the Zoom meeting if you know the right answers. You can raise your hand and write something in the comment space. And you can do so in the first part as well. So if you've got any questions, then feel free to ask them. Take this away. Oops. Okay, obviously I'm not able to read any Ukraine, so I've got a second monitor with the original slides in English. And the slide you see now is about the indication for pulmonary lung function testing in the chest physician. The indications obviously are for the diagnosis of respiratory diseases like COPD and bronchial asthma. We use the lung function test as well to differentiate the causes of dyspnea, which of course can be of cardiac origin, pulmonary, and neuromuscular. We screen in health examinations. We use the lung function testing for early detection of damage caused by inhaled noxious agents. We monitor the cause of bronchopulmonary disease. We use the lung function testing in monitoring the therapy of a bronchopulmonary disease. And of course, we use the lung function testing in occupational health monitoring and prevention, for example, for those who are professionally exposed to allergens, inorganic dusts, or smoke exposure, and so on. And of course, we use the lung function testing in preoperative diagnosis. If we talk about the indications, we've got to talk about the contraindications as well. And the contraindications for a pulmonary function test are, as you could imagine, acute life-threatening clinical pictures of any kind. For example, an acute myocardial infarction, an acute fulminant pulmonary embolism, large ascending aortic aneurysm, or a tension pneumothorax. There are some relative contraindications as well, like extensive pneumothorax, and there it is not wise to perform a lung function test within the first few weeks. As well as for large abdominal or thoracic operations, you should wait 1 to 4 weeks postoperatively to do a lung function test. Eye, brain, or ear operations, there it is variable.
Шо?
Приезжает, а он, короче, ночью работал.
Okay. Special care should be taken also when the patient is reporting hemoptysis or of unknown origin for infectious causes. In this slide, I will try to, it seems to work. I will show you a film where you can see a lung function test performed, and even though it is in German, I think the most important message you will get. So take care, and I will ask afterwards if you've seen the most important things.
Hier zeigen wir den Ablauf einer ganzkörperplethysmographischen Untersuchung, die der Lungenfacharzt durchführt. Die Untersuchung wird häufig vor und nach Inhalation eines Medikaments, also insgesamt zweimal mit 20 bis 30 Minuten zeitlichem Abstand durchgeführt. Die Ergebnisse bieten eine wichtige Entscheidungshilfe für den Arzt, welche Behandlungen und/oder eventuell welche weiteren Untersuchungen durchgeführt werden sollten. Die Untersuchung besteht aus 3
Alan, you could comment in English if you wish and just take the tone off.
Yeah, I'll do it afterwards. But can't you hear the tone? No.
Zweitens, Messung
Okay, well, obviously this lung function test was performed in German, so you probably didn't understood what the nurse said. But as far as you saw the lung function test, there are some points I want to make. The first point is the person who performs the lung function test as a patient is sitting in a kind of telephone cell, a body plethysmography we use broadly in the middle of Europe. Maybe you use them as well in the Ukraine, at least in the big clinics. It is performed in sitting. The lung function test is divided in two parts. The first part is with closed door, and the second part is with an open door. Then the patient is wearing a nose clamp, has got a mouthpiece between the lips, and which is the most important thing, the nurse who is doing the lung function test with the patient tells the patient exactly what to do. And this is something the nurses here in my practice need to learn. They need to be confident in shouting out to the patient what he is supposed to do during the lung function test. Only then the lung function test can be performed correctly by the patient and is repeatable. So that is something the nurse has got to learn. So we go on to the next slide. Yeah, here you can see the next slide. The lung function test needs some preparation beforehand. Every day we use the body plethysmography, we need to calibrate it. We need to set the outer temperature and the air pressure. That is quite necessary if you use one of these big body plethysmographies. We need to know the body height and the body weight of the patient and the sex of the patient. The measurement is then taken in sitting position, as you saw. The patient gets a nose clip, which closes the nose airtight, and the patient needs to take the mouthpiece between the teeth with the tongue lying under the mouthpiece. The lips need to close the mouthpiece airtight. And if the patient is not able, because of a paresis in the face, for example, to close the lips tightly, you can use a snorkel mouthpiece, as you can see here down in the picture. And then the patient is told to breathe in and out slowly and without any strength. After that, the nurse tells the patient to breathe out as fast and forceful as possible. And then directly after that, to breathe in as deep and fast as possible. And again, as fast and forceful out as possible. And then again, the patient goes into a calm breathing with normal breathing without any force. And this lung function test is then, as we saw in the video, performed 3 times in a row. Graphically, the lung function test is then printed out in a flow volume curve. In the flow volume curve, you see the expiration phase divided from the inspiration phase. The purple line is the expiration phase up to the peak expiration flow, the so-called PEF. And this peak expiration flow, you can actually measure with these simple devices, with these peak flow meters, we call them in Germany. You can either use a device which is really cheap to get without any electricity, and you can use a digital device. You can even now get devices which are connected to your mobile phone. We like to use these peak flow meters, for example, to monitor an asthma, or in small children which are not so good in performing a lung function test and a body plethysmography, maybe to diagnose an asthma. And the patients, they get one of these peak flow meters back home. They get a protocol, and we tell them to perform a peak flow meter test every morning and every evening, to document it in this protocol. And if there's a deviation of more than 20%, then it could very well be that there's an asthma underlying the symptoms of the patient. It is necessary for you all to know that the lung function test is quite variable during the daytime. That is because of the cortisol built in the body during daytime, within the inner circle, within the inner the watch of the body, as well as melatonin and the body temperature. So the best time to do a lung function test is during 11 and 1 o'clock in the at daytime. The worst time to perform a lung function test would be between 4 and 6 a.m., but that is obviously a time where most people don't work or still are asleep. For most questions in pulmonology, you don't need one of these expensive body plethysmographies. A spirometry, handheld spirometry, can answer most of the questions you want to know. And this is one of those you can buy for much less money than you would need to spend for a body plethysmography. You can even perform a lung function test, if you like, on horses. I'm not a rider, so I can't really say anything about horses and asthma, but all the riders of you know that asthma is quite severe illnesses for horses. Next, I will focus on the volumes we measure during the lung function test. And we divide between the so-called dynamic lung volumes and the static lung volumes. The dynamic lung volumes you can measure perfectly with one of these much cheaper handheld spirometries. If you want to measure the static lung volumes, then you will need one of these telephone cells, these body plethysmographies. I will explain later on why. The dynamic lung volumes, they consist of, for example, the inspiratory vital capacity, the IVC, the 1 second capacity, the FEV1, and from that we use the so-called Tiffany quotient to define the obstruction. The peak flow we've already had, that is the peak of expiration in a forced expiration, And then we can take a sharp look at the half time of the expiration, or 25, respectively 75% of expiration, which gives you a clue about the small airways, whether they are obstructed or not. In order to focus upon the static lung volumes, like total lung capacity, for example, we need to measure the lung, or we need to use the body plethysmography. We need to measure the intrathoracic gas volume and the functional residual capacity. And this is performed by measuring the occlusion pressure during resting breath. By doing this, we can register the alveolar pressure as an oral pressure. These two signals we then need to measure the functional residual capacity. Those are the so-called static lung volumes, and with the dynamic lung volumes then taken into account, we can say something about the total lung capacity, which then is an important measurement, for example, to divide between obstructive and restrictive disorders of the lung function. The degree of the occlusion pressure, the higher the functional, the lower the degree of the occlusion pressure, the higher the functional residual volume then is, which is then printed out by this graph. And those are the functional, the static lung volumes, not the functional, the static lung volumes. That is, in first place, the functional residual capacity, the expiratory reserve volume, the residual volume, and the total capacity. And again, we've got a quotient between the residual volume and the total capacity, which defines an overinflation, which we, for example, can see in COPD patients. So we then have the volumes measured at the patient, and we want to compare those volumes with patients that are known to be healthy on the lungs. And we do this by printing out a percentage to the target value, and a deviation of 20% from the target value is regarded as a limit value between normal and pathologic. The historical reference values we use here back in Germany originate from the European coal and steel community, and they were measured in the 80s, in the 70s and 80s of the last century. And obviously, those values were measured at young men between 15 and 45 years, which were lung healthy. So every time we've got a patient which is younger or older, or every time we do a measurement at women, those are the women, those are the men, we then need to calculate the reference values we are comparing to. And it could then very well be that in elderly, for example, we overestimate or underestimate the volumes compared to the reference volumes. Therefore, we need to take a closer look at the important factors that of the reference values of adults, which make a difference. For example, the age. The lung function deteriorates with age. The body height, the body height, bigger people have greater lung volumes than smaller people, obviously. The sex is important, and the origin of the person is important. And therefore, in 2012, there was a big a big investigation which performed lung function tests not only on healthy Caucasian white people, but all over the world. They measured lung function tests between the age of 3 and 95 years to gather some more and better reference values. And since 2012, we've also got a new method to compare the actual value with a reference value by using the SET score, which is a mathematical combination of the percentage, predicted value, and the variability observed between the individual, which makes the function testing more accurate. But nevertheless, regardless whether you use the SET score or the percentage predicted values, you should always take into account the sex and the age of the person, and it is always difficult to interpret only one measurement. The lung function test has got a strength when you have got several testing and you can have a look at the values in a row. Then you can really good use the lung function test as a diagnostic device. As I mentioned, in first place, we do we perform 3 tests in a row. And we do this because we want to perform a reproducibility of the test. We want to show that the patient is really doing 3 times in a row the same testing with the same force. And for that, we've got criteria. One of the criteria is that the expiration phase should at least be 6 seconds long. Or within the expiration, the volume should be less than 25 milliliters over 1 second. And the next criteria is that the 3 attempts should not divide more than 5%, as you can see here in the pictures. If it does so, then we've either got to perform the lung function test again, or you can take one of the lung function tests out and only use 2 of the tests to calculate the volumes. There are some other plausibility checks we use by looking at the volume curve. If the ascent is not steep enough, then it could very well be that the patient did not perform the lung function test as good as possible. So the nurse needs to tell the patient to do it more quickly and to repeat the lung function test. If you see in the expiration phase a gap like we see here, then it is probably because of coughing. If the patient needs to cough during expiration, then the nurse needs to tell the patient to go off the mouthpiece, to cough as much as possible or as needed, and then perform the lung function test as well again. If the expiration phase has got a round curve like we can see here in this picture, then again, it could very well be that the patient is not doing or is not using the force he could do to perform a correct lung function test, and he should be asked to do it more rigid, again with more force. If in the expiration phase, in the expiration phase, the curve is smaller than the other curve, then again, it could be very well be that the patient did not perform as good as he could do. And the same as if the expiration phase is not connected directly to the inspiration phase, then the time of expiration was not long enough. Again, the patient is told to do the lung function test again. And if the expiration phase breaks off like it does in the last picture here, then it could very well be that the patient went off the mouthpiece and the lung function test should be performed again. This lung function test is a normal test. As you might see, we see that the volume curve and the expiration, the inspiration phase, that they are performed correctly. We see underlying the reference curve, which is printed out here like a triangle. And we can see just by looking at the volume curve that the lung function test is normal. If you take a closer look at the volumes themselves, you will see that the quotient between the FEV1 and the vital capacity, the Tiffinor quotient, is bigger than 80%, is actually 100%, which rules out an obstructive lung disease. We see that the FEV1 is by 100%. Then the next volume I would like to look at is the total lung capacity is at 100%. And the vital capacity is, well, at 95%. And as I said before, a deviation of 20% defines from normal to pathologic. So this is a normal lung function test, as you might very well see. We then have got obstructive ventilation disorders, for example, like in COPD or in asthma. And if we take the orange curve as the normal volume curve and the blue curve as the volume curve of the patient, then usually in obstructive lung diseases, the expiration phase is smaller than the normal volume curve. The more obstructive the patient is, the smaller the blue curve gets, obviously. And if there's a severe obstruction, then you might see in the volume curve here in the expiration phase, the so-called emphysema band. At least that's what we call it back in Germany. Even though we know that lung emphysema is not the cause of this emphysema band, but the collapse of the bronchi and the bronchioli during expiration causes this band here to be shown. And those are the references from normal, dividing the pathologies volumes according to the criteria of Gold. A light obstructive ventilation disorder would mean that the Tiffinor quotient should always be smaller than 70%, which is the definition for obstructive lung disease. And if the FEV1 is bigger than 80%, then there's a light obstructive ventilation disorder. If the FEV1 is between 50 and 80%, and then there's a medium obstructive ventilatory disorder. And if the FEV1 is smaller than 30%, then there is a very heavy or very severe obstructive ventilation disorder. Then we've got the restrictive ventilation disorders. Those are the patients that don't have problems with their bronchi themselves, but with a total volume of the lung because of fibrosis or because of a disorder of the spine or the thorax itself. Here the volume curves are smaller than those of a lung healthy person as well. But it is not like in an obstructive lung disease. The volume curve in the expiration and inspiration are both smaller than in a normal at the normal lung function test. And again, we've got references to divide between normal and pathologic. A light restrictive ventilation disorder would mean that the forced vital capacity is bigger than 60%. A medium deterioration is between 40 and 60%, and a heavy restrictive ventilation disorder is below 40%, with the forced vital capacity compared to a healthy lung function test. So, in summary, I think the most important volumes you can measure with the lung function tests are in spirometry. Those are the volumes, the dynamic volumes you can measure with a smaller handheld spirometry, are the vital capacity, the FEV1, and the quotient between the FEV1 and the vital capacity. If you've got a body plethysmograph, you can measure the static lung volumes, which are then important to take a closer look at restrictive lung disorders. Those are, for example, the residual volume, the total capacity, and the quotient between the residual volume and the total capacity, which then defines the the Überblähung in German in obstructive lung volume disorders like COPD or asthma. That was the first part of the lecture, as I mentioned beforehand, and I would like to show now some lung function tests that patients performed here in my practice. And I think it would be now, well, I would like you to tell what is normal or what is not normal. So if you want to open your microphone, or if you want to raise your hand and write something in the chat space, then I would be thrilled if you do so. Don't be shy. There are no bad answers. There are only bad questions. That's what we say in Germany. So in first place, I've got a normal lung function test. As you can see, the volume curve, the expiration and the inspiration seems to be quite all right. We've got the reference curve here, the black triangle, and the expiration phase is more or less on the volume curve of the normal. So if you take a closer look at the lung function volumes themselves, then you see that there's no big deterioration, at least not more than 20% to the normal. So this is a normal lung function test. So this lung function test, what is the problem with this patient? Does any one of you want to answer the question? You can do so in Ukraine if you like, but then I can't understand what you're talking about. You can do so in English, or if you can do so in German, then do it in German if you like. Okay, there's a raised hand, and if you want to open your microphone, I would be thrilled if you can say something.
Thank you, Doctor. So I'm still a student, but then in line with the lecture you just gave, I can observe that there is some deviation from the reference curve in this function, but then the Vmax is 102%. So I don't know much, but I just noticed the deviation from the reference curve. Thank you.
Okay, yeah, you're absolutely right. If you take one message back home after this lecture, then it would be that before you go from top to down, maybe start with the quotient between the FEV1 and the vital capacity, which is this, which defines the obstruction. And if if this quotient is lower than 70%, like it is in this patient, then you can say that there's an obstructive ventilation disorder taking place. And then you go to all the other lung volumes. There was another person which opened his microphone. Do you want to say something?
We have a question on our chat. Yes, how correct is to use data on the total lung capacity, which are obtained on computer tomography examination in functional diagnosis?
Okay, this is a question which should a radiologist answer, and maybe not a chest physician. Yeah, I think that a CT scan is a good tool to see an emphysema, which then could cause in an well, in an too high residual volume, in an over volume. But if you want to, well, if you want to really divide between an obstructive and a restrictive volume disorder, or if you want to say really something about the lung function test, I think a CT scan is not the right device to do so. A lung function test is much more sensitive for those questions.
Thank you very much. Maybe other questions, especially for our specialized of pulmonology or maybe TB.
Thank you very much, Dr. Strassburg. So, what is in this spirography? Please explain us.
Okay. Well, as I mentioned before, I would start with the quotient between the FEV1 and the vital capacity, which is low, below 70%. And that is that defines an obstructive ventilation disorder. So it's an obstructive disease this patient has got. It could either be an asthma or a COPD. We don't know yet. We need to talk to the patient or need to perform a bronchospasmolyse test, which we didn't in this case. But we can say that it is an obstructive ventilation disorder with an FEV1 of 72% of the normal, which is a mild obstructive disorder. And if you then take a look at the total capacity of the lung, we see that the total capacity is even better. Sorry, that was too fast. Is even better than it should be. And that is because there's much more air in the lung than in a normal person. The residual volume is more than 160% of normal, 3 liters. Where only 1.8 liters should be. So that is quite usual for a COPD patient. And this is a lung function test of a COPD patient in stadium 2 after the GOLD criteria. Even though the residual volume is elevated, the vital capacity is still normal. Usually you see in those patients a reduced vital capacity, at least during exercise, if you perform the lung function test after exercise, for example. Okay, and we performed a bronchospasmolyse test. The patient got 2 hubs of salbutamol. We use this test, of course, then to divide a COPD from asthma, as you probably heard in one of the lectures you've already had. And we see that the lung function test does not improve by salbutamol, which is then usually the case more than in COPD patient than it is in asthma, even though it can occur in asthma as well. So, as already mentioned, this is a COPD patient in stadium 2 after the GOLD criteria. Okay, this is a lung function test with a volume curve which looks quite similar to the patient we have already had. And as I already mentioned, start with the Tiffinor quotient with the FEV1 to the vital capacity and look whether the quotient is bigger or smaller than 70%. Again, it is smaller than 70%, so it defines as an obstructive ventilation disorder. And then you can take a look at the FEV1, which is around about 60%, still a mild obstructive disorder. And again, then the total capacity, which is normal, but the trapped air in the lung is too high. The residual volume is bigger than it should be. It is with 3.7 liters at 155% of the normal. And respectively, the vital capacity is increased down to 81%. This is again a COPD patient in stadium 2 after the GOLD criteria. Here we can see at the volume curves that the expiration is getting one of these emphysema bands I already talked about. That is when the bronchi collapse during expiration. And again, first take a look at the Tiffany quotient, which is smaller than 70%, defining the obstructive ventilation disorder. The FEV1 is only at 42%, which is already a severe obstructive ventilation disorder. And then again, the total capacity is normal, which usually is in COPD patients, but the residual volume is elevated at 174%, and respectively, the vital capacity is reduced down to 74%. And funnily enough, you will learn if you see a lot of COPD patients that not really the FEV1 is the cause of the symptoms the patients have, but the reduction of the vital capacity because of the trapped air in the lung. That is what makes the patient symptomatic. And if the patient is then treated with the right anti-obstructive agents, we can try to get down the residual volume to increase the vital capacity, and that then takes down the symptoms of the patient. Usually in COPD, unfortunately, the FEV1 doesn't really change during or under the therapy the patient gets. This is another example for a severe obstructive ventilatory disorder. Oops, sorry. Went down the wrong direction. No. Oh. How do I get back? Oh, this is going into the, yeah, I got back, yeah. Again, start with the Tiffany quotient at 30%, a severe obstructive ventilatory disorder with an FEV1 of 23%. The total capacity is normal, but the residual volume is nearly 8 liters, which is really catastrophic. And respectively, the the vital capacity is down to 58%. The bigger the residual volume, the higher the volume curve in this graph gets. Yeah, so if the graph is going up, then you know that the residual volume is high.
Alan, there's a question from Petro Potaiko. What conclusions and recommendations do you make when spirometric parameters are within normal limits, but expiratory CT shows significant evidence of obstruction, for example, by multiple air traps?
Okay, yeah, this is surely a question not by a student, but maybe by a chest physician himself. If you've got a patient with a bronchiolitis, for example, with an infection of the very small airways, then you might see in expiratory CT scan, which is not a common technique used in a praxis like I've got, but maybe in a hospital, then you could see that the lung function test seems to be quite normal. But if you then take a closer look at the MAF50 and the MAF25, then you might see that those volumes are less than normal, further less than normal. And for those patients, I would also perform a diffusion capacity test to see how good the oxygen, which is inhaled, can be transported through to the blood vessels. But this is actually not a topic of my lecture today. Maybe next time in summer, if I get invited again, I can talk over the diffusion capacity test as well. But the questioner is totally right that the lung function test can look quite normal, even though in expiratory CT scan a significant obstruction is seen. I hope that I answered the question to your satisfaction. If there are no other questions in the chat space, then I go on to another lung function test, if my computer allows me to do so. Yeah. Okay. This volume curve here looks quite different to those beforehand. It is not elevated in this graph. It is slightly smaller than the normal reference curve. And if we take a look at the Tiffany quotient, which you do first in all cases, you will see that it is above 70%. It is at 83%, which rules out an obstructive ventilation disorder. And then you can take a look at the total lung capacity to see whether there might be a restrictive ventilation disorder, and obviously there is one. The total lung capacity is only with 5.6 liters at 75% of the normal. Respectively, the vital capacity is increased as well at 61%. And this is a patient with mild restrictive ventilation disorder, for example, in a beginning lung fibrosis. And there's the CT scan of this patient, where you can very well see that there are scars seen here in the tissue of the lung. And this is a beginning lung fibrosis. You can already see the honeycombing here. So it might be an UEP. Well, that is what you could suspect. This is another example for a restrictive lung disorder. Again, the Tiffany quotient is above 70%, which rules out an obstructive disorder. The total lung capacity is down to 1.7 liters, respectively 34%. With vital capacity down to 55%, and this is already a mild to severe restrictive ventilation disorder. Usually you find, according to the decreased total capacity and vital capacity, an increase in the FEV1 as well. Yeah, and that is not because there's an obstructive ventilation disorder, but that is because those patients that have got a decreased total lung capacity, they will then have a decreased FEV1 as well. But this is a patient with a restrictive ventilation disorder. Well, another example, again, the Tiffany quotient is above 70%. The total capacity, lung capacity, is down to 63%. The vital capacity is at 58%. And this is, again, a mild restrictive ventilation disorder. So I'll take a look at, well, I'm totally perfect in time. It is 6 minutes to 3. Maybe we've got some time for some more questions, if you like. I would be thrilled if you've got some. Okay. If you repeat it again, I didn't quite get that.
Вопросы, ни хера никто не понял.
Can I ask a question, Doctor?
Yes, of course you can. That's what I'm here for.
Yes, please. So with when you showed us the demonstration of the patients undergoing the lung function test in the closed chamber, you emphasized the patient was sitting. So my question is there a particular preference to why the patient has to sit or stand? And if that's the case, does it apply as well to the mini devices, the handheld devices that we can get? Do you also need the patient to take a particular protocol sitting when undergoing the lung function test with the handheld spirometry and other devices?
Yeah, that is actually a quite good question, because if you see a choir singing in a church, for example, they don't sit, they stand. Why do they stand and don't sit? They stand because then only they can use the whole volume of the lungs. They can use the belly to pressure the lung, to force the air. So to be honest, the lung function test would be best be measured in standing. But then we might get a problem in the closed-in chamber, because there are people which are 2 meters of height, and then there are persons that are only, don't know, 1 meter 5 at height. So the definition or the lung function test, they defined it to do it during sitting. You can as well do a lung function test with a Hans spirometry in lying position. For those people who have got a neuromuscular disease, for example, you can see whether those people would improve the lung function test with a breathing device. But all the volumes defined are in seated position, even though it is not the best position to breathe.
You had a cigarette here on the last.
Yeah, genau. This is the last slide I usually use for presentations. Well, it is a slide to remember that smoking is doing harm to your lungs. But of course, you already know that.
For the colleagues in Kharkiv, what is the proportion of your patients in hospital that are cigarette smokers?
No one want to answer, Christoph.
Yeah, there's dead silence. Olga will know, or Petro.
Yes, I'm here. I'm sorry, I don't know the answer.
Okay, there's one more question in the chat space, okay, have you ever encountered a case of a patient trying to cheat on a test? In Ukraine, if an occupational disease is diagnosed, you are entitled to disability. Compensation is paid for this, so some patients try to cheat the machine. Yes, of course. This you've always got to keep in mind. The lung function test is a test performed by a patient, and the patient can cheat whenever the patient wants to. Therefore, we've got these criteria we use to recognize if a patient cheats. If the volume curve is somewhat looking awkward, then probably the patient is cheating. And we've got the same in Germany as well. If there is a patient who wants to be compensated for disability, then he might cheat. So if you suspect a patient cheating, then go as a doctor and stand next to the lung chamber and observe the patient while performing the lung function test.
Okay, Alan.
Yeah.
Thank you so much. Please stay in the line. I need to go for the TB consilium, but I'm sure that there may be 1 or 2 more questions.
Yes, I'm here. I'm still here.
Thank you for being with us.
Yes, thank you for organizing it all.
Ukraine for being here today. Have a very nice weekend. We are all hoping for the best and be ensured that there are some people in the world, especially from our country, but also from France and from UK and from the Baltics and the Scandinavians who are standing strong on your side. Bye, bye, bye.
Bye, Christoph. Thank you.
Thank you very much. Шановні колеги, якщо у вас є якісь запитання, будь ласка,